Afternoon, everyone, and welcome to this webinar in our New Strategies in Breast Cancer series. I'm Dr. Leif Ellisen, Program Director of Breast Medical Oncology at the Mass General Cancer Center and also a laboratory investigator here. The goal of this series is to provide our patients and supporters an opportunity to hear from leading physician researchers about innovations and advances in the field. Today's topic is new innovations in breast cancer clinical trials. First, though, before I introduce the topic and our panel, some housekeeping details. You don't need a microphone or video capabilities to participate in the webinar. At any point in the webinar, you may type questions through the Q&A feature in Zoom. Note that you can enter your questions anonymously if you prefer. The webinar will be recorded so that we can provide you with a shareable link to the event afterwards that you may share with friends, family, and colleagues. Although you can enter your questions at any time, we will have a single Q&A session after all of the presentations have occurred. So here at Mass General, we emphasize an integrated and multidisciplinary care program in order to personalize therapy for each patient. Key innovations we've seen in breast cancer treatment over the past decade include targeted therapies, immunotherapies, precision medicine approaches, and also the growing need for survivorship programs as the number of breast cancer survivors increases with improved treatments. And as you will hear today, there is also a long-held recognition at Mass General that we must make special efforts to ensure that all populations in our community can benefit from these advances. So today we will be focusing on innovations in clinical trials that seek to establish new treatment approaches and improve quality of life and outcomes for our breast cancer patients. Clinical trials provide a highly rigorous framework in which to test and develop these new therapies in collaboration with our patients who elect to enter these trials. While large confirmatory clinical trials are generally funded by industry, many of the most new and innovative trials are initiated by our clinician investigators themselves. These investigator-initiated trials require funding from grant and other philanthropic sources to make them possible. Mass General is uniquely positioned to carry out such investigator-initiated clinical trials because of our infrastructure, being a large cancer center embedded in a large general hospital, embedded in the huge biomedical research institution that is the Mass General. Now, this year, the COVID pandemic has affected all of our lives in many ways. And I wanted to show you one slide that tells you, it illustrates the way that the pandemic has affected our clinical trials and the infrastructure. So here on the left, you can see the number of inpatients at Mass General with COVID during the course of the spring. And this is in the month of April, where the peak was, all the way out through August, where we've been able to maintain low numbers. And you will see corresponding with that peak of COVID inpatients was a substantial decline in the number of patients we were able to register for clinical trials. Now, of course, life-saving treatments and life-saving clinical trials were able to continue, but because just about all of clinical trial funding is allocated on a per patient enrolled basis, this COVID surge what resulted in a major hit to our clinical trials infrastructure. And that's one of the reasons why we thought it was important to share with you how important clinical trials are, what a difference they make, and what they do for patients and for the field and for breast cancer as a whole. So now I'd like to introduce the panelists in the order in which they will speak today. First, Dr. Aditya Bardia, who is Director of Precision Medicine at our Center for Breast Cancer. As you will hear, Dr. Bardia recently led the national development of a program all the way through FDA approval of a paradigm-shifting medication for triple-negative breast cancer. Secondly, you'll hear from Dr. Laura Spring, an attending physician and a rising star in the development of new and potentially curative therapies through a focus on clinical trials for early-stage breast cancer treatment. And finally, Dr. Beverly Moy, the Clinical Director of Breast Medical Oncology here at Mass General and the Director of Cancer Equity. Each speaker will give you highlights about innovations in their respective fields. Then at the end, we will have a question and discussion session. We hope that what we share with you today will be inspiring, and with the link that we will provide thereafter, that you can share it with friends, family, and colleagues. And now I'd like to turn over the floor to Dr. Aditya Bardia.
I'd like to thank Dr. Ellisen and the MGH team for organizing this webinar. I feel honored and humbled and look forward to speaking with you about innovation and clinical trials. So let me start with, why should we consider a clinical trial? Our goal at the Breast Cancer Center is to deliver the best care to patients with breast cancer and to advance the field. And often, clinical trial is the strategy that can achieve both. Anything that was a standard of care was in clinical trials before. Clinical trials offer the possibility for a patient to get access to cutting-edge therapies, and that is why we do clinical trials. I'm a breast medical oncologist and would like to start with a patient story. A 36-year-old female with triple-negative breast cancer. This patient was diagnosed with triple-negative breast cancer and underwent lumpectomy, followed by standard chemotherapy, ACT as we call it. Within a year of completion of the adjuvant chemotherapy, she was found to have metastatic disease. She presented with shortness of breath in the ER, had scans which showed nodules in the lung. The nodules are biopsied and confirmed that it was breast cancer, and it was triple-negative breast cancer, the same cancer that she had less than a year ago. And this was despite surgery and standard therapies for breast cancer. Over the next 12 months, she received various chemotherapy regimens, including platinum, eribulin, with limited success. And this is very frustrating for the patient and the provider. However, this is not uncommon in triple-negative breast cancer. Triple-negative breast cancer is the most aggressive form of breast cancer, tends to affect young women, African American. With standard therapies, the response rates are low. Median progression-free survival is short, and clinically, it's a major unmet need in the field. So it's a problem. How do we target it? How do we target triple-negative breast cancer? One thing to consider is that cancer has several unique properties that are different from normal cells. The internal machinery of a cancer is different. And it's this difference that gives it the advantage, the survival advantage, the proliferation advantage. So can we convert its strength into its weakness? Can we convert what's different in cancer cells and utilize that difference to target it? We know that cancer cells overexpress several antigens receptors that are not present in normal cells, but are unique to the cancer cell, which gives it the advantage for proliferation. So if we target these unique antigens, we could potentially selectively target cancer cells while sparing the normal cells. And this exactly is the principle for a class of therapies called antibody-drug conjugates, or ADCs. ADCs target antigens that are overexpressed in cancer cells and relatively spare the normal cells. Antibody-drug conjugates have three components: the antibody, a linker, and a toxic payload. And the idea is that the antibody would bind to an antigen that's overexpressed in cancer cells and not so much normal cells, get internalized, and then release the payload to the cancer cells while relatively sparing the normal cells. So it's a way of giving high doses of toxic therapy to the cancer cells, but not the normal cells. It's what we call a smart bomb. And early on in 2013, we got interested in developing one such antibody-drug conjugate for triple-negative breast cancer, sacituzumab govitecan. It's a long name, a complicated name. We also call it SASI-GOV or SG. SG is an antibody-drug conjugate that targets TROP2 that is overexpressed in triple-negative breast cancer. The drug also has a bystander effect, by which some of the SN38 can affect cells that do not express or express the antigen at very low quantities. So thus it can address tumor heterogeneity. So this patient enrolled in a clinical trial with SG, and she had a very nice response with the drug. Besides visceral mets, this patient also had chest wall disease that was causing a lot of pain. The treatment led to complete resolution of the chest wall mets. There was not only shrinkage of the tumor seen on scans, but clinically you could see that the tumors were shrinking and the drug was working. She was able to discontinue her pain medications. And thus, both from a quality of life as well as quantity of life, she derived benefit from the drug. Over the years, given the promise of this agent, we led the clinical development of this agent and were able to provide the drug to a number of patients with triple-negative breast cancer as part of a clinical trial at our center. In April 2020, FDA granted accelerated approval to SG for treatment of patients with metastatic triple-negative breast cancer. The approval was based on 108 patients who were treated with this drug, 30 of which were from MGH. Thus, we were able to provide access to this promising cutting-edge therapy to patients before it was FDA approved through a clinical trial. The approval represents a big win for patients in the management of triple-negative breast cancer. But a lot more needs to be done. We need to accelerate the progress that has been made. We need to continue to build on the progress. The response rate with this agent was 33%, but we need to move that to 50%, 70%, 80%, even higher. We need to accelerate the efforts to fight this devastating disease. And how would we do that? We hope to do this by understanding therapeutic resistance, understanding why tumors progress, why all patients do not derive benefit from this agent. And based on mechanistic research, build combination therapy. We are interested in focused research that can help us understand therapeutic resistance to this agent and develop combination therapies. The second strategy is to expand the use of this agent for other breast cancer subsets, such as hormone receptor positive breast cancer. Even patients with metastatic hormone receptor positive breast cancer, similar to triple negative breast cancer, can receive multiple therapies. And sometimes it can be very frustrating just moving from one therapy to the next. We are working on analyzing tumor specimens so we can understand the antigen expression and pathways that confer sensitivity to this drug. And if the same antigen and pathway is also present in hormone receptor positive breast cancer, you could target hormone receptor positive breast cancer as well. So thus, through research, biomarker research, we are hoping to bring this agent for patients with hormone receptor positive breast cancer as well. And then finally, moving forward, can we prevent metastatic breast cancer? We are interested in building on the progress and providing access to this drug for patients with early breast cancer in a clinical trial. The goal is to further improve outcomes and significantly reduce the morbidity and mortality for our patients with breast cancer. And clinical trials are a key component that could make this possible. So I'd like to now hand this over to Dr. Spring.
Thank you, Dr. Bardia, and thank you to everyone for joining today. You heard from Dr. Bardia about advances in the metastatic setting. And I think, well, it's great we have more and more options to offer our patients with metastatic disease, and we will certainly continue those efforts. Ultimately, we want to prevent metastatic disease in the first place, as Dr. Bardia mentioned. So we know that most patients with breast cancer first present with localized disease without evidence that disease has spread. And unfortunately, a subset of these patients will experience a metastatic recurrence. An example of this is the patient story that Dr. Bardia shared. So it is therefore critical to improve the treatment of localized breast cancer in order to prevent these recurrences from happening in the first place. And this is the area where I focus most of my clinical trial efforts. And we know that among patients who have localized breast cancer, we know that those undergoing chemotherapy prior to surgery, also known as neoadjuvant therapy, tend to represent the highest risk group for recurrence. And this pre-surgical or neoadjuvant setting is therefore the next place we tend to bring a drug after its efficacy is established in the metastatic setting. So in addition to focusing on higher risk patients, the neoadjuvant setting also offers an ideal setting where drug development can be explored, and that's because response to therapy can be directly assessed. The tumor is in place when you start the therapy, you can follow that on exam and with imaging, and then when the patient goes to surgery, you have a direct evaluation of the response to the therapy. So a homegrown clinical trial we are especially excited about is one called the NeoStar trial, which features the use of the exciting drug Dr. Bardia told you about, sacituzumab govitecan. And this is for patients with localized triple-negative breast cancer being treated in the neoadjuvant setting. So in this trial, patients receive 4 cycles of sacituzumab as their first treatment for triple-negative breast cancer. And then an adaptive or personalized approach is used from that point based on the response to therapy. So some patients may proceed right to surgery if the response has been excellent. Others may need more traditional chemotherapy prior to surgery. So given the success of this drug in the metastatic setting, we believe and hope that the responses in the neoadjuvant setting will be better than the responses we see to traditional chemotherapy, and also hopefully carry less side effects as well. I think one of the major strengths of a trial like this is the ability to interrogate potential markers that may predict response or resistance to the therapy. So in this trial, we actually have a biopsy of the tumor that's taken before the treatment starts, and then that can be compared to samples after the treatment, such as those from surgery. So the availability of these pre-treatment research biopsies and post-treatment specimens allows a number of innovative analyses in the lab to be done to better understand mechanisms governing treatment response and resistance. And ultimately, this is what will lead us to better understand why some patients respond better than others. And the ultimate hope is that that will contribute to more effective treatment strategies rather than a one-size-fits-all approach. And this important translational work related to this homegrown clinical trial is actually being done in collaboration with Dr. Ellisen's lab. And so while the clinical aspects of a trial like this and the drug itself is, often supported by industry, this deeper dive into really understanding who benefits from the drug is not supported by industry. And instead we rely on grant funding and philanthropy to explore these important questions. And this is a trial that we also hope will serve as a platform to study additional promising combinations with this exciting drug. So for example, in the future, we plan to open an additional cohort for higher risk triple negative patients that looks at combining the sacituzumab with immunotherapy. And then we also hope to explore this drug in the neoadjuvant setting in patients with estrogen positive breast cancer as well. But of course, I think what we really want to work towards ultimately is thinking about how to prevent breast cancer in the first place. We believe that future advances in this area will require the comprehensive analysis of breast tissue specimens, both from those with breast cancer, but also those with benign findings and sort of high risk findings as well on biopsy. So through philanthropy in the past, we've been able to start an exciting program called the Breast Biopsy Project. And this has allowed us to offer patients undergoing a breast biopsy at MGH the opportunity to contribute extra samples for research to allow a number of questions about the development of breast cancer to be explored. And this is a type of project that really starts out as exploratory, and then initial studies will lead to more specific hypotheses. So when you think about it, given this really broad nature of a project like this, it can be quite hard to obtain grant funding to get a project off the ground, because unfortunately, many grants want you to sort of almost have it all the way figured out before they'll take a chance on you. So for something like this that's really exploratory, philanthropy ends up being incredibly critical. And philanthropy is what got this project off the ground. And it's been very successful so far. We've been offering it to patients for well over a year now. And about 70% of our approach patients have agreed to contribute research samples. And based on some of our initial work, we have now been able to obtain some specific grant funding to explore specific hypotheses related to these samples. So thank you for listening, and as you heard, feel free to send any questions through the chat. I think at this point, I'll pass the virtual microphone over to Dr. Moy.
Hi, everyone. Thank you, Dr. Spring. My name is Beverly Moy, and as you heard earlier, I'm the Clinical Director of Breast Oncology and the Director of Cancer Equity at the Mass General Cancer Center. You've just heard about some of the most exciting breakthroughs in breast cancer treatment that have been discovered because of clinical trials. In this modern era of cancer treatment with molecularly and genomically driven therapies, The fact of the matter is, often some of the breast cancer treatments available can only be obtained through clinical trials. However, many groups of breast cancer patients are deprived of access to clinical trials based on their socioeconomic status or the color of their skin. Lack of access to clinical trials is one of the most important reasons why patients from underserved communities are less likely to survive their cancer. For example, if you're Black and have breast cancer, you are almost twice as likely to die of your disease compared to a white woman. If you're an underrepresented minority or have a lower income, you are far less likely to participate in a cancer clinical trial due to lack of access. I have spent most of my career studying disparities in cancer care, looking at interventions and advocating for policy changes to improve cancer equity. Like most things you're passionate about, my interest came out of personal experience. When I was training in oncology about 20 years ago in New York City, my immigrant Chinese father was diagnosed with prostate cancer. I knew all of these fancy genitourinary oncologists at Memorial Sloan Kettering, but I couldn't even get him in the building because he didn't have the right insurance. So with all of our new drug discoveries, especially in the field of breast cancer, we need to close the disparities gap to make the biggest strides to improve cancer outcomes. You know, we talk as an oncology community about discovery of drugs all the time, but we need to talk about discovery and delivery of cancer care. And we need to prioritize the delivery part because we need to make sure that all patients with cancer have access to the best cancer therapies possible. I am so proud to be part of Mass General and to direct its cancer equity efforts. Mass General Hospital's mission statement expressly says that our goal is to provide the best patient care to the diverse communities we serve. It's in our DNA at Mass General. We have made tremendous progress in community outreach and improving access to clinical trials. Over the last several years, based really because of initial philanthropic support, we have built a meaningful and trusting partnership with Boston Medical Center, the safety net hospital serving the city of Boston. Again, this partnership was really catalyzed by philanthropic support with donors who really believed that this relationship could be important and to figure out how we could provide resources to make this happen. So together, Boston Medical Center and Mass General applied together for and have been awarded several research grants studying the effects of cancer disparities in our breast cancer patients. More recently, we actually launched a virtual monthly tumor board for Boston Medical Center to present their complex breast cancer patients to our group here at Mass General in order to assist them with treatment recommendations and in particular to discuss whether their particular patient is eligible for clinical trials. We actually just had our latest tumor board earlier today, this afternoon, and they presented 5 very complex cases, and we talked about what clinical trials their patients might be eligible for. Most recently, and this is pretty exciting, we signed a legal agreement to open Mass General principal investigator initiated clinical trials at Boston Medical Center so that patients who are being treated with their primary oncologist there don't have to lose their primary oncologist in order to participate in trials. They're actually in the process of opening that NeoStar trial that Dr. Spring mentioned earlier, looking at sacituzumab in the early stage triple-negative breast cancer setting in hopes of improving cure rates. And actually, as Dr. Bardia mentioned earlier, triple-negative breast cancer disproportionately affects Black women with breast cancer. So this is exactly the kind of research we should be providing, and access to this clinical trial is really important to this community. When they can't open a clinical trial, they send patients to Mass General, especially for our early phase, really promising genomically and molecular driven clinical trials. Our overarching goal in our cancer equity program is to make sure that all patients with cancer but especially breast cancer, in the city of Boston has access to any clinical trial for which she is eligible. What is exciting is that all of these efforts will benefit future generations of breast cancer patients. We will finally have more inclusive research with diverse patient participation so that our results will be more meaningful. But what is particularly important is that patients will no longer be deprived access of some of the best and most promising breast cancer treatments. This is a major social justice issue. The horrific recent events affecting our country with police brutality and structural racism really signal a turning point for us. Obviously, the second major crisis facing our country has been the COVID-19 pandemic. COVID-19 has laid bare for all of us how patients in underserved communities suffer worse health consequences. It's our responsibility as cancer providers to reflect on ourselves and those around us to address structural racism in healthcare and society. I'm so proud of how Mass General has responded to the COVID crisis, and Mass General has continued to make important strides to improve cancer care for all patients, regardless of their socioeconomic status and race. But this is a really critical time in the healthcare industry where COVID-19 has really resulted in, in tremendous financial losses, to be frank. And we're in a climate where we have really restrained resources to devote to important causes like this. But I do know that I do have faith in Mass General, because when we truly embrace a problem, amazing, innovative things happen and the job simply gets done. So I'd like to turn this back over to Dr. Ellisen.
Thank you very much, Dr. Moy, as well as Dr. Spring and Dr. Bardia. I think those were really fantastic presentations and articulated really distinct but interwoven and mutually beneficial types of efforts going on in the setting of clinical trials and access. We've had a few good questions come in, so why don't we start with one? So the first question that's come in is, someone writes in, Dr. Ellisen, I'm interested to know what are the big challenges you face and that you anticipate in this area over the next few years? And maybe I'll take a stab at that and turn it over to a couple of the other panelists for their opinions. If I put on my laboratory hat for a moment, someone who's been investigating cancer as a researcher for more than 25 years, the real complexity of human cancer is how diverse it is, and how even in breast cancer, even in the same subtype of breast cancer in individuals, might be very, very different due to the complex way that cancer develops as a cumulative group of mutations. And so what that means in the end is that if we're really going to beat cancer in everyone, really eliminate breast cancer, we really have to understand it at the level of the individual, why each tumor in each individual might be different. And if you think about a clinical trials development program, that suggests that there's really tremendous burdens on the system to run trials that have the level of analysis and complexity to allow you to tease out that heterogeneity and those differences between one patient and another. And you've heard some examples of those kind of trials here with Dr. Spring talking about the biopsy project, where if we can profile large numbers of tumors, link those profiles to how the patients respond to specific therapies, we can begin to understand this individualization that needs to be done for treatment. But this, of course, adds tremendous expense, right? It's no longer the paradigm of just taking a drug off a shelf and giving it to a patient, or giving it to every patient with breast cancer and seeing does the tumor shrink or not. That's totally insufficient for how we would like to improve outcomes for breast cancer in this day and age. What we need to do is, on the back end of these clinical trials that look at how patients and tumors are behaving and responding to the therapy, is to understand why. And that's a tremendously complex and expensive endeavor. So one of the biggest challenges that we have is really being able to build into each clinical trial all of that infrastructure, a lot of what goes under the rubric of translational research, but is actually really clinical trial research, understanding why we see the effects we see in the clinical trials, which allow us to then move forward and ultimately to personalize therapy for each patient. So I think for me, that's probably the biggest general challenge that comes to mind in this whole area of drug development. I'd like to get Dr. Bardia's opinion. Dr. Bardia, what would you say on this question of largest challenges in this area of trying to improve therapy through clinical trials?
Yeah, thank you, Dr. Ellisen. I would echo what you were saying. Better understanding tumor biology and markers that predict response to therapy and resistance, that is a major challenge in the field of breast oncology. The other is choosing the right drug for the right patient at the right time. And with advances in genomics, we can now profile tumors. And with advances in therapeutics, there are a number of therapies that are available. But how do you select the best therapy for an individual with X mutation? And it's not uncommon when you profile the tumor that you discover multiple mutations, and trying to understand what is a driver mutation that's driving the tumor versus what's a passenger mutation that is there but would not necessarily drive the tumor. And choosing therapy for the driver mutation but not the passenger can be challenging. At our institution, we started the Molecular Tumor Board to exactly address this issue of matching to help select the right drug for the right patient. The other big challenge we have is expansion of this to the community. As Dr. Moy mentioned, access is a big issue. A patient will not derive benefit from a drug he or she cannot take. And if you don't get the drug, you can do the best research and science, but it's not going to have an impact on patient outcomes. So I think access, including access of this molecular genotyping and therapy selection, is another big challenge.
Yeah. Thank you, Dr. Bardia. And Dr. Spring, we really realize how important these early stage trials are, because ultimately those are the ones that are going to have the biggest impact on cure rates in the long term. But of course, there are unique challenges to doing trials in the early stage setting. And how do you look at that picture in terms of the fact that in particular, we're doing more and more in the early stage setting, which allows us to accelerate the research, but also poses challenges?
Agree. I think we really have to think about what's the best question and how should that question be explored. So traditionally in breast cancer, a lot of drugs were first studied when they got to early breast cancer in the adjuvant or post-surgical setting. And the issue there is that, you're almost, the only way if it's effective is if there's a recurrence or not. And so it's hard to truly know, and you have to follow patients for quite a long time. And it's certainly an important setting, in certain agents like CDK4/6 inhibitors. There's been a lot at the conferences in news lately about exploring those agents in the adjuvant setting. But ultimately, that's why I'm such a big proponent of looking at these agents in the neoadjuvant or pre-op setting, because you have a tumor in place, you can look at the before and after, you can more easily explore the biologic questions as well in the lab. So I think it's really thinking about the agent, where it works best, and the best setting to explore it in.
Thank you. And Dr. Moy, you talked so eloquently about collaborations with particularly institutions that serve our underrepresented populations as really one of the keys to disseminating, providing access, and to expanding the benefits of this research to everyone. What do you think is the real driver that's going to allow us to get the most out of these kind of collaborations and bring this research to our patients everywhere?
Well, so I think that there are many aspects to being able to make sure that that all patients have access to clinical trials and the best cancer care. I think the first thing is that, I really worry during the COVID-19 pandemic that a lot of people, from underprivileged or not populations are not going to get their cancer screening. And that's going to lead to, frankly, more advanced disease at presentation. And I think we've all been in clinic over the last few months, and I've been pretty surprised at the new cases we've been seeing, and in particular, we'll hear things like, oh, I noticed this a few months ago, but this, I was afraid to come in. Our more underserved, vulnerable patients are even less likely to come in and get screened. What we really need to do is create an environment that is welcoming, that is caring, and that is trusting. And I think that a lot of patients in underserved communities really kind of, the people they trust tend to be the places in their community health centers, maybe in their safety net, and places like Mass General where we have, therapies that, those places which are wonderful may not have access to. We have to be respectful in our partnership. And and we have to really be humble in that, knowing that they do some wonderful things that we can learn from, and and we can learn from best practices as well. So coming in with that common mission and goal of providing the best cancer care, and that is all about the patient, is really, I think, the key there. I would like to say, though, that the question that was originally posed to us is, what are the biggest challenges that we see facing clinical trials? And since I'm a policy nerd, I do have to think about this from a policy perspective. You showed the slide earlier about how the COVID-19 surge affected our clinical trial enrollment, or how it really plummeted out of necessity. What we didn't say, as you know, Dr. Ellisen, very well, is that our labs had to close, right, for a period of time. So operations were really suspended, correlative science was suspended, and research was suspended. We have a lot of makeup time to make up for. I think about our young investigators whose careers were really placed on hold and really put in peril for this period of time, and we're trying to figure it out and make up for that now. Several of us from Boston actually advocated on Capitol Hill virtually a couple of weeks ago, and we talked to our entire Massachusetts delegation from the House of Representatives and the Senate to talk about this crisis, because this period of suspension, which may or may not happen again, really has its consequences. And we advocated for the COVID-19 relief bill to give us additional NIH and NCI funding to help make sure that we can make sure that the labs do the research that they do to support clinical trial infrastructures. And you're probably not surprised to hear that that probably isn't going to happen. Nothing's coming through the Congress anytime soon. So basically, there's going to be a patch and a Band-Aid, and we're going to need to figure out how to come up with that funding. But we need to. You heard from Dr. Bardia and Dr. Spring, we're really poised to make such incredible strides, especially in breast cancer, in the most feared subtype of breast cancer. We finally made this huge discoveries. Now is not the time to suspend discovery. So I think the challenges more immediately are to really try to bolster our operations at a time where I think that we're really in crisis.
I think that's an excellent answer, and it's actually a great segue because the next question we have, it really is about breakthroughs and asks, what does the panel see as the biggest breakthroughs in cancer diagnosis and treatment? What are the things are there things on the horizon that are really going to be game changers for breast cancer? And I would say, kind of as an introduction to answer the question, it's ironic in some ways that, I think of everyone in the breast program, such an incredibly talented and hardworking group of individuals. In some way, everyone has their nose to the grindstone, and sometimes we forget to look up and share the collective experience we have about the progress that's being made. But I think, myself speaking personally, as someone who's very engaged with the lab and with technology at the same time as seeing patients, the extent to which the new technologies are going to allow us in the near term to make really previously unheard of advances, I think is really extraordinary and continues to accelerate. One example from my own practices is in the setting of high risk for cancer through genetic mutations and inherited breast cancer, inherited ovary cancer, where we've developed some good screening tools, but some are very imperfect. For example, there's no screening tool that works at all for early detection of ovarian cancer. But with the advent of new technologies, we're rapidly being able to develop tests that are both sensitive and specific enough to give us an indication about when those cancers might be developing at the earliest stages. And that's going to be a game changer in terms of what women have to think about and undergo who have this type of high cancer risk. Similarly, these same sorts of technological innovations are going to help us to understand the very earliest steps in cancer development. As I said, cancer is multi-step. Traditionally, we couldn't understand the very early steps because the step happened at individual cells, and we just didn't have the sophisticated technology to look in the way at individual cells. Well, now we actually can do that, and we're seeing for the first time how early the chromosomal damage, for example, occurs even in cells that look normal under the microscope. Well, that's important because it tells us that a defect occurs very early on in the process of cancer development. But it also tells us that there's a flaw in those damaged cells that might be able to be exploited by the right kind of short-term drug treatment, for example, as a cancer preventative. So the new technologies in this field are leading us to the early detection, toward the biomarkers of impending cancer, and also to the biology that's going to lead us to prevention. And in the part of the work that I do, I think this is an incredibly exciting development that is just accelerating more and more rapidly because of technology. So maybe I'll turn it over to Dr. Bardia, and what do you see in terms of the things that you are most excited about? Because I know there's a lot of them.
I will build on what you mentioned, Dr. Ellisen, that we have advances in technology, we have advances in diagnostics. And the next step is to have therapies for patients with breast cancer based on the advances in diagnostics and the advances in technology. And this is usually done in the setting of a clinical trial. And I think that is where over the next few years we'll have the biggest innovation. The way we do clinical trials is changing. The previous model was you would treat a large number of patients to see a small benefit. And the model now is just the opposite. It has been turned, where you would treat small number of patients, but to see a large benefit. This N of 1 model, where you're trying to understand what's driving the tumor for an individual and choosing therapy based on tumor biology, not just treating everyone with breast cancer the same way. So this personalized or precision medicine approach and clinical trials that support that, and that could even lead to approval, I think is going to be a big changer in the field of breast oncology. In the field of breast oncology, approval based on phase 1 or phase 2 trials was unheard of. All the drugs were approved based on large phase 3 trials. But in the past 5 years, we have at least 3 drugs that were given accelerated approval based on phase 2 trials. And I think we are going to see more and more of that. And that would be a winner for patients as well as the field.
You think about the efficiency factor there, right? Not having to do a trial with thousands of patients to bring a new medicine toward the population who benefits from it most. I mean, extraordinary efficiency brought forth by our ability to be able to do the trials in a precision way. Yeah. Dr. Spring, what are your thoughts on your most exciting breakthroughs? I mean, so many in the area of early phase and early stage treatment.
Yeah, I guess jumping a bit off on what Dr. Bardia said about the modernization of clinical trials. Another example is how some neoadjuvant trials are now being done where they are having dual primary endpoints to both establish a treatment as being efficacious, but also making the trial large enough so we can look at long-term outcomes as well. So instead of having to do 2 trials, now the full approval can actually probably happen out of 1 trial. You might get that accelerated approval first based on, the primary outcome at the time of surgery, but then you'll also have built into the trial the ability to follow enough patients long-term to really see recurrences and mortality all decreased from that. I think another really exciting area that relates to both early stage and late stage breast cancer from a technology and diagnostic standpoint is blood-based monitoring of disease, which is an area that we at MGH are heavily involved with. So I think, we're seeing a number of different projects here, both to monitor patients in the advanced setting to get a sense if treatment is working and to develop a more personalized approach based on how mutations are changing over time in response to treatments. Then we've also brought this technology to the early breast cancer setting as well. We have everything from projects looking at using it from an early detection standpoint, all the way to trying to follow patients at high risk of recurrence to see if, a marker in the blood like circulating tumor DNA might give us an early sense. And then the bigger question is, well, what can we do about it? And Dr. Bardia recently opened a very exciting trial exploring the question just like that. So I think we're going to see more and more of this in the future as well.
Yeah, and I think particularly the data is showing that in the setting of breast cancer, it's likely to be one of the most powerful areas in which this blood-based monitoring is going to help us guide our therapies. Because for so many breast cancers, for example, recurrences happen, but they might not happen till many years down the road, right? And so if we could know from the beginning that there had not been sufficient therapy or there had not been a sufficient response, the idea that we could intervene and eliminate that recurrence that might happen 5 or 10 or even more years later, I think is an extremely, extremely exciting possibility. And some of the data in breast cancer is suggesting that that's going to be the case. So I think that that's absolutely it. And then you can apply each of these sorts of technologies and monitoring and sub-segmenting to all the new types of therapies that everybody hears about: targeted therapy, immunotherapy, combinations. The ability to guide it through all the things we've been talking about, I think, provides such efficiency, such power, and really allows us to accelerate the whole process. What would you say, Dr. Moy, about where you see optimism, in the field of, I think the fact that we're recognizing we're having a national conversation about this in many ways gives us optimism. What would you say?
I think that, I've just been amazed, especially over the last few years, at how much better treatment has become for our patients. I'm thinking about a patient actually who was referred to us a few years ago, a young woman from Boston Medical Center who'd been through multiple therapies and her disease was getting worse. She saw Dr. Bardia enrolled in one of his trials based on a marker that she had, and did extraordinarily well in that trial. And when her disease progressed on that trial, she went on yet another one and responded again, and in another trial responded again. And through this time, was able to get finish her PhD, get married. That would not have been predicted when she was first sent to us, not at all. And to live a really great life too, with very few side effects. And that's what these targeted therapies can achieve. So it's really been an incredible game changer in that we've recognized breast cancer is not at all one disease. It's many, 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 many diseases. And the technologies that we have now at our disposal with circulating tumor DNA, tumor genotyping, you name it, we can find therapies that patients tolerate well and live longer with. So I think that it's just such a great job that we have. It's so incredibly exciting to be able to offer hope to our patients and to provide this. It's such an amazing privilege.
Yeah, I think you're exactly right. And again, along those lines, there's yet another good question which follows, which is, what does it really take, right? What is actually the formula that makes these kind of trials and makes progress happen, right? Is Mass General uniquely positioned that? Can any group do it? What are the key elements in driving the research and the clinical trials to make progress faster? I'll say the same thing that I say to my junior faculty folks, fellows, even students who interview here for positions at Mass General. I say that Mass General is really the right size to do the most extraordinarily innovative research. And the reason is that Mass General is large enough that we have a huge infrastructure for research. We're embedded in the large Harvard community with affiliations with MIT and beyond. And yet, we're not too large that everybody is in silos, right? There are frankly some places, and particularly some cancer centers, that are so large that every disease, every research application, every department is in their own silo, in a different building that never talks to one another. I think for us at Mass General, the idea that early on, we wanted multidisciplinary care, that is all the physicians seeing the patient together in the same room at the same time to discuss in each individual patient's care plan in a coordinated way, has something that has lent power to the research that we can do, because that multidisciplinary care has now been applied in the research setting where it's multidisciplinary research having to do with approaches related to medical oncology, surgical oncology, radiation from the treatment standpoint, and then piggybacked on these translational research applications in computational biology, artificial intelligence, new molecular biology approaches And really having people in the same room talking to one another, I think has been much of the secret sauce for Mass General. And it's because we are this large hospital, because we are a large research institution, it's all under one roof here. And that is what lowers the barrier to all the complicated but interrelated things that we're doing here. I mean, that's my personal perspective on it. This time we're going to go in reverse order, and we're going to start with Dr. Moy, because I'd like to hear what you think is unique about, and what's really important, what makes it possible, and what's unique about Mass General.
So I agree with everything you said. I would think, though, that the number one reason that makes Mass General so special is the people. You know,
everyone says that, yes.
And it's so true, though. Like, look at our colleagues.
It is.
I mean, so not only are our colleagues brilliant, innovative, just thoughtful, you know, responsive, you know, team, collegial, you name it. And we've got, you know, from the basic scientists to the translational scientists to the clinicians to nursing, you know, research staff, we attract really the best of the best. But I will say the nicest people, right? Like, just, you know, the community, it's, you know, the camaraderie, the community we have, it's all about the patient. And so when you get a collection of people like that together, only great things happen. And, you know, a lot of institutions may say, you know, we have labs, we've got clinics, you know, we've got this, you know, sorry, but not like the people that we work with. I'm really proud of our colleagues and our team. So I think that's what really makes us uniquely positioned to be successful.
Dr. Spring, you're the newest faculty member at Mass General. What would you say about that? What are your impressions in coming to Mass General that was different in other places where you trained or worked?
I mean, I think I'd largely been in the Harvard system, but experiencing some different aspects of it. And I think what's unique about Mass General is that we have this major cancer center, but within this great hospital. So you have the resources of that hospital and all of the other specialties. So now, you know, our therapies now, whether it's immunotherapy or a targeted therapy, while they're doing great things, we also see, you know, some side effects here and there, and it's, you know, that may affect other organs. And it's great that we have really top specialists in every area to collaborate with and really get people the top care. So it goes back to the people again, but I think having a major cancer center literally embedded and attached to a hospital is actually an advantage compared to maybe just being a standalone separate cancer center, because really we have the resources of the entire hospital.
Yes, I totally agree. I mean, Dr. Bardia, you've trained at some of the most prestigious academic institutions in the country. What struck you when you came to Mass General, and what about it has made you so successful, apart from all the innate talent that we know that you have?
Yeah. Well, thanks, Dr. Ellisen. I can realize how it's tough to go last after Dr. Moy and Dr. Spring. I think the thing that struck me was the integration. The integration that's there at MGH, and as Dr. Spring mentioned, the best pathology, the best diagnostics department, as well as the team members, the best in surgery, the best in radiation oncology, and the best in medical oncology as well. And if you think of a patient's journey, there are 3 steps. The first is diagnosis, the second is therapy selection, and the third is getting access to the therapy. And here at MGH, you have all the 3 components. In terms of diagnostics, any advances in pathology or radiology, because the cancer center is integrated with the hospital, we get to hear of them many times even before they are published. In terms of advances in therapies, you have a wonderful team, again, a multidisciplinary team, one of the few centers that truly has a multidisciplinary conference every day to talk about a patient with cancer, with medical oncology, radiation oncology, and surgery. And then finally getting access. If you know that the therapy is going to be effective, ensuring that the patient can get access to that, and the work that Dr. Moy is doing to improve access. There's no other center that has all these components together, this integration, and I think that's part of the secret sauce.
Thank you very much. I totally agree. So in the last few minutes, I really wanted to bring it back to the patient, because everybody here in this webinar has been touched by breast cancer in profound ways. And our #1 mission at Mass General is to care for patients and to bring better treatments for patients. At the heart of that really is a lot of what we've been talking about in the realm of clinical trials, where we know that we have to do better for every breast cancer patient, and we have to do it in this rigorous way that requires the entire infrastructure that we've been discussing this afternoon. We talked about the hit that COVID put on our entire clinical trials infrastructure. But because of its essential and central importance to the mission of Mass General, our most critical priority right now is really supporting clinical trials. And so we're looking for all the ways that we can possibly do that. We have more ideas, more approaches, and more ways that we can help patients than we have support for. So in many ways, what we do is only limited by the support that we can get for it. So thank you all for attending today. It's been a pleasure to speak with everybody. It's been a great pleasure to interact with my colleagues here in this forum. If you'd like to follow up, you'll all be receiving a link to the webinar that you can share with friends and colleagues. You can always reach out to our colleague Marissa in the development office, who will be happy to discuss with you ways that you might be interested in supporting the program. If you don't have her contact information, you can reply directly to the email invitation you received for this panel. Also, be on the lookout for additional iterations or additional, chapters in our series on new strategies in breast cancer. So with that, I'd like to close and once again, thank everybody for attending. Have a good afternoon and bye-bye.
Hi, everyone.